My name is Zahir Othman Al-Tahir Babikir. I'm a consultant in infectious diseases at Sheikh Shahbour Medical City. I'm also an adjunct professor at Khalifa University in Abu Dhabi, UAE. I'm going to talk to you today about antimicrobial stewardship and the use of digital technologies to support it. So without further ado, I don't have any disclosures to share with you. And I'm going to, as I said, share with you some of the core functions and challenges of antimicrobial stewardship programs, and also discuss ways to boost antimicrobial stewardship through digital health interventions. So please feel free to chip in at any point in time if you've got any question or any thoughts, and we'll try and make it as interactive as we possibly can. So I think most of you are familiar with the building blocks of antimicrobial stewardship. So basically, there has got to be a legislation or a diktat from Ministry of Health or Departments of Health committing hospitals to developing antimicrobial stewardship programs. And obviously, hospital leadership has to come up with the financial package to support a core antimicrobial stewardship team, which is usually co-led by an ID physician and an ID certified pharmacist. And this should be manifested in the form of giving them the appropriate full-time equivalent to dedicate to stewardship activities. Also, you've got to have your local antibiotic formulary and some guidelines. The latter is not essential, but it would be preferable to have it. So once you've assembled your core team, then your really core function is to promote appropriate antibiotic use at the patient level. And this involves inpatient as well as outpatient activities, and obviously emergency departments as well. So stewardship programs usually focus on developing antimicrobial guidelines that are customized according to their local antibiogram. They should also develop some clear guidelines as to when to convert from IV to oral route, when to de-escalate, when to stop antibiotics, how to monitor antibiotics for therapeutic efficacy, and all these kind of day-to-day routine activities done by the stewardship programs. So once you've got your stewardship program up and running, then you've got to strive for the next high level of performance. You have to continue monitoring and evaluation. You have to identify areas for improvement. These can manifest themselves during the process of prospective audit and feedback. You've also got to invest in education. Involve new joiners in stewardship by talking to them about antimicrobial stewardship at the moment they join the hospital, and lots of things you need to look at and try and improve. For instance, you can look at your formulary, you can look at your branded antibiotics, see if you can swap them for generics and so forth. So in essence, this schematic representation more or less outlines the core functions of antimicrobial stewardship programs. However, the real world is very, very different. Antibiotic prescribing is a very complex process and is fraught with challenges. So first of all, I'm sure all of you have witnessed firsthand that there's sometimes lack of ownership of antibiotic prescribing. In most hospitals, the most junior physician, typically a resident or intern, is the heaviest antibiotic prescriber, and that's either done at the behest of the consultant or the attending physician. And sometimes decisions about stopping, starting, de-escalating, this ownership of these decisions sometimes becomes opaque and difficult to hold people to account. Also, some physicians just care about the now and then. They want to give what they think is the best antibiotic, irrespective of whether the spectrum is just too broad, and forgetting the public health ramifications for their action, forgetting the impact on the patient's microbiome. Also, I think as physicians, most of us would like to adhere to best clinical practices, We value evidence, but whether we apply it to our day-to-day practice, that's a different matter altogether. Also, there are diverse priorities between different clinical teams. For instance, the ID team is keen on, for instance, narrowing or de-escalating or stopping, whereas the medical or ICU teams have got different priorities, for instance. So sometimes you have to reconcile these priorities and focus on what is really best for your patients' clinical outcomes. So not an easy process, and I think it's also complicated by the fact that most physicians think that they know how to prescribe antibiotics. So you've got to focus on identifying opportunities for improving your stewardship program, and this can be brought about through various means. So there are different interventions that you can use to improve the efficacy or the effectiveness of your stewardship program. So people love education. However, it requires moderate effort, but the impact is quite low. Restrictive approaches have been used in terms of identifying what spectrum antibiotics that should only be prescribed after obtaining a pre-authorization code from a pharmacist or an ID physician. Again, this requires a lot of effort in terms of identifying these antibiotics and also policing this process. Prospective audit and feedback, this is very labor-intensive process. I'm sure all of you are familiar with that. But it's highly effective because you actually achieve something. You actually either allow antibiotic prescription to go ahead or de-escalate or stop or convert from IV to oral. So it has the highest impact by the patient's bedside, but it's quite labor intensive. Requires a lot of input from clinical pharmacists and ID physicians. What I see as the low-hanging fruit really is process improvement. This requires really moderate effort, but the impact is really quite high. So by process improvement, I'm really referring to the antibiotic prescribing process. If you look at this process and identify areas where you can actually improve it, that will really have a very good impact on patients' outcomes. Right, so I'm sure you're familiar with the 4 moments of antibiotic prescribing. So in essence, this is about thinking, does my patient have an infection? And if so, you need to collect the appropriate cultures and start empirical therapy. That's customized to your local antibiogram. And then 48 to 72 hours later, you've got to rethink, is there any evidence of infection? If no, then stop. If yes, then what's the microbiology report saying? Then you can narrow or you can convert to oral. And then you have to give a stop date. And that's quite important in terms of restricting unduly long duration of antibiotics. So this process focuses the minds of antimicrobial stewards in trying to influence this process by intervening at certain points. So making the diagnosis, you've got to identify your main infection syndromes, your pneumonias, your UTIs, and your skin and soft tissue infections. Develop empirical antibiotic guidelines for these conditions based on your local antibiogram, and then have clear criteria for converting from IV to oral antibiotics, and then have stipulated durations in your guideline. Nowadays, as you know, less is more. Pyelonephritis can be treated with a 5-day course of antibiotics or 7 days maximum. You don't have to go for longer than that, even in that bacteremic. So this is what I mean by looking at this decision-making process for antibiotic prescribing and trying to influence it. So what are the current practices in this area? So I'm sure you're all familiar with restrictive practices, having restricted antibiotics. At our hospital, we've got 19 restricted antibiotics. These antibiotics would require a pre-authorization code from a clinical pharmacist or an ID physician. And if they get prescribed out of hours or in emergency situations, this will trigger an auto-consult by the ID team. Also, you can see there are some persuasive practices. I'm sure you're also familiar with the handshake stewardship approaches, and also disengaging in a telephone conversation, maybe with the clinician at the other end, trying to reach a consensus and agree whether to continue or stop antibiotics. So by and large, these are the current practices, but we think there's a third way. We think there are other things we can do, and this is where digital health interventions come into play. So those of you who follow politics might have heard about the nudge theory. It's basically about choice architecture. It's about rearranging it in a way that makes a certain choice more appealing to you as an individual. And when you opt for that choice, you don't feel that you've been forced to do it. You feel that you have done it because of your own free will, and the choice is just attractive and you just do it. So this is very commonplace in politics, and those of you who followed the British politics, David Cameron, the former Prime Minister, the current Foreign Secretary, was actually the one who championed it quite a lot in British politics. So this concept has been borrowed by stewardship programs, and some of you have already seen some microbiology reports that adopt a cascading format or put certain interpretive comments to deter clinicians from unnecessary prescribing of anti-MRSA or anti-pseudomonal drugs. For instance, an upper respiratory tract sample or a sputum culture a report will say MRSA or Pseudomonas species not isolated, and that is enough to stop physicians from prescribing empiric vancomycin or cefepime or Pictaz. For not this to work, you have to make sure that you are able to utilize them in a way that will make that change in behavior scalable, i.e. it can be rolled out to the entire hospital and you can reap the benefits in terms of your antimicrobial stewardship outcomes. So are there any questions before I delve into specific points about our local experience at SSMC here? I'm sure you've experienced some of the stuff I've just mentioned. If no, we'll proceed. So I'll tell you about Sheikh Shahboub Medical City. This is the largest tertiary/quaternary hospital in the UAE. It has a maximum bed capacity of 750 beds, and it has cutting-edge facilities and technologies. It's also an academic medical center. We've got academic partnership with Khalifa University in Abu Dhabi. And our infectious disease division is formally known as Tropical and Infectious Diseases Division. And that's because of the volume of tropical infections we see at our hospital. So in terms of our antimicrobial stewardship program, we've got various levels of intervention. So if I summarize these by program level and the functions of the ID physician and the pharmacist, at program level, we develop guidelines, we disseminate them, we develop antimicrobial restriction policy, we have an induction program for new joiners, and we identify areas for improvement and carry out QIPs on a regular basis. The ID service is unique in not only in the UAE, but I think in the whole of the Gulf region, if I may say. We have a whole raft of proactive and reactive services. So we have a proactive bacteremia service. Any blood culture result that's positive will trigger an auto consult to the ID team. We also have a proactive prospective audit of all restricted antimicrobials, and we review these patients and give the parent teams feedback. We also practice handshake stewardship. to the high-risk areas, so critical care. We have got the National Burns Unit in our hospital. We also have a hem-oncology ward that also sees patients with bone marrow transplantation. We have also reactive ID consult services that you're familiar with. Somebody will just pick up the phone and ask for an ID input, whether it's about empirical antibiotic choice or about de-escalating, or we don't know the diagnosis, please help us out. And we are also unique in the sense that we actually have our own cohort of our ID inpatients. So we look after cases with complex TB, complex HIV, tropical infections, travel-associated infections. We work very collaboratively with our clinical pharmacists who do a fantastic job in carrying out prospective audits and provide feedback to their teams. They also provide excellent therapeutic drug monitoring services. So basically anybody who's receiving VANC or GEN, for instance, that will trigger a consult by the clinical pharmacist, who will then review the prescription and ensure that the patient is receiving the correct antibiotic doses. So this is just an overview of how the service is organized or translated to day-to-day kind of actions. In terms of our innovative approaches, we have implemented what's dubbed as the escalating MDT approach and documented this in a publication by our clinical pharmacist, ID clinical pharmacist, Ahmed SIDA. So basically, we evaluated the impact of having an MDT intervention on the stewardship outcomes among inpatients. And the purpose was also to highlight the vital role that clinical pharmacists, who are the unsung heroes of stewardship, play in promoting better antibiotic prescribing. So basically, the model we currently have in place, the ward clinical pharmacist will review all patients receiving antibiotics. They will discuss each case with the ward physician. And if there is doubt or disagreement, they will escalate to the ID clinical pharmacist, who will then review the prescription for any further input. And again, if they feel the case is complex or there is still disagreement, they will escalate to the ID physician. And the ID physician will make a final decision on the antibiotic measure for the particular patient. So that study showed very good impact on various stewardship metrics, but what I'm interested most to show you here is the impact on cost. So by just working collaboratively, we were able to save around 6 million dirhams over a 6-month period. So basically, these interventions are very impactful, and it's worth investing in fostering collaborative links between ID physicians and clinical pharmacists and supporting them in their day-to-day work. So that's one initiative. That was one of our QIPs. Another one, we looked at using the medical record system, the electronic medical record system, to support stewardship. So how did we do that? As I mentioned earlier, we've got auto-generated consoles. This is system-based consoles for all positive blood cultures or positive CSF cultures or PCR panels. If someone has resistant TB, this will flag up straight away. If somebody tests positive for malaria or HIV, this will trigger an auto consult by ID, even if we haven't requested that test. And we've also got auto-generated consoles triggered by prescribing any restricted antibiotic. This obviously generates a lot of work for the ID team, but the impact has been quite remarkable. So for instance, our ID team conducted around 8,000 inpatient consultations last year. 8,000, and it's quite a large number of consults, but as you know, there's very strong evidence to suggest that early intervention by an ID physician in bacteremic patients or candidemic patients improve their outcomes. So we went even further because we noticed that according to our antibiogram, around 40% of our Staph aureus isolates are actually MRSA. Now, MRSA screening is not reimbursable by the insurance providers here, and therefore we cannot mandate MRSA screening preoperatively. But what we do is, once we identified somebody as being MRSA colonized, the system will nudge the physician to sign a prescription. So the prescription is really ready for the physician to say, okay. So it's a nudge, and it's very hard to say no. So that improved the decolonization rates among our patients. Also, we've had a look at our surgical prophylaxis guidelines, and we have, provided additional recommendations for patients who are known to be MRSA colonized or have MDRO colonization, or they're at high risk for colonization with any resistant organism. So that quite improved the workflow for surgical prophylaxis. And what we're currently working on is introducing soft stops for antibiotics. So we've already started actually with diagnostic stewardship. I'm sure you're all familiar with your GI PCR panel and all the queries that can come up when the C. diff target is positive, and whether the patient has got C. diff or not, and all that kind of jazz. But we have implemented a soft stop that will actually make the physician understand the utility of the GI PCR panel. And we're doing currently some work on respiratory PCR panels. We're trying to look at the way they are reported. As you know, some of these respiratory panels will also report the resistance mutations, and that sometimes creates some interesting discussions with clinicians who are non-specialists in infectious diseases. And that often triggers unnecessary use of broad-spectrum antibiotics. So again, we're trying to work on that and introduce some soft stops for physicians who are trying to order these panels. Also, we have introduced an IV to oral switch soft stop as well. So any patient who's receiving IV antibiotics for 72 hours, the physician or the prescriber, the physician will get an alert saying this patient has received 72 hours worth of IV antibiotics. Maybe you could consider a step down to oral if the following criteria are met, and it's all listed. And if the physician decided to override it, they'll have to give a reason for that. So this is currently ongoing as part of a quality improvement work we're working on at the moment. We are also trying to curb unnecessary use of certain antibiotics. So empiric use of anti-MRSA or anti-pseudomonal agents, especially in critically ill patients. So we've got some text prepared for these. And we've also got some text targeting the use of duplicative anaerobic coverage, especially by our surgical colleagues. So these are all nudges that have been shown to work. There's some evidence from literature that they work actually. And as I said, it's all about really choice architecture, redesigning things and making one choice more acceptable than others. I'm going to move on to share with you our experience in adopting a mobile app to support our antimicrobial stewardship. Quite happy to say that we are the first hospital in the Middle East to adopt it and introduce it, and now we think we are reaping the benefits of such an intervention. So what's the evidence supporting mobile application platforms and antimicrobial in antimicrobial stewardship? Well, there's good evidence to suggest that they improve access and utilization of guidelines. They're also more convenient. One of my colleagues told me that, quote, I may not know where my child is, but I will definitely know where my mobile phone is. And also there's been some impact on antimicrobial resistance by these apps. What is still unknown is whether these mobile apps have got any impact on some of the hard outcomes like mortality, length of stay, and DOT, and others. So one of the stuff that we use to consider when we're interviewing various providers and assessing their products, we were looking as to whether the app was a standalone app, i.e. not linked to EMR. Because if it's a standalone app just hosting antibiotic guidelines, that will actually make your life a lot easier in the sense that you don't have to get bogged down with patient confidentiality and other things. This is an app that can be accessed by anybody, and it includes the locally approved guidelines. We were also keen to ensure that the availability of the mobile app is available 24/7. It can be downloaded free of charge, and also the app for us was quite important to host a decision support tool. For instance, simple things like CURB65 score that helps ED physicians decide whether somebody needs to be admitted if they have respiratory symptoms by just following the algorithm on the app, and that will tell them which CURB65 score the patient has and what would be the most appropriate antibiotic treatment, whether it's IV or oral, and whether admission is recommended or not. We're also looking as to whether the app will actually host our antibiogram and also monographs, detailed drug information about renal drug dosing and therapeutic drug monitoring and what have you. And we introduced the app formally at the end of October 2021, and again documented our experience in a publication that you see on your right on the screen. So in a sense, we are kind of leaders in the region when it comes to mobile apps, and I'm going to share with you the impact it has had since it was introduced in 2021. So this is the provider that we have signed up with, and this is actually a screenshot that I took during the Antibiotic Awareness Week. So again, it's a screensaver. Anyone in our hospital will see this on their desktop, and they have the ability to scan the QR code and download the app free of charge. So these are the figures for 2021 and 2023, plus the green bar for Q1, that's 2024. So as you can see, there has been a steady increase in the number of active unique users, and that has got a strict definition that the app developers provide us with. So quite happy with the uptake. Our hospital has around 400 physicians in total. The number can be slightly up or down depending on the number of fellows and residents who rotate through our hospital. But that's more or less the number of physicians we have. Obviously, we've got clinical pharmacists and nurses who also use the app. So it's interesting how different groups use the app for different purposes. Physicians usually use it for looking at antibiotic guidelines, sometimes antibiogram, because we are a tertiary hospital. We receive patients from all over the UAE, and sometimes they want to look up the antibiogram for the UAE, which is also available on our app, and decide what would be best empirical antibiotic choice. Clinical pharmacists focus more on drug monographs. Likewise, residents and interns look at both antibiotic guidelines and monographs. Nurses look specifically at therapeutic drug monitoring and also infection control recommendations. The app tells you about each pathogen and what kind of infection control precautions are needed for each one of them. Although we have a mobile app, we still have a web version that sits in our intranet. So look at these numbers. These numbers are quite huge. So for Q4 in 2023, the number of screen views on the mobile app were exactly 110,000. This is just in Q4 over a 3-month period. So we're quite happy now that our guidelines are actually being accessed and utilized by physicians and pharmacists and nurses. Whereas prior to the implementation of the mobile app, we had no idea as to who's reading our guidelines and where they are benefiting from it. And actually, the app allows us to know exactly which guidelines are being looked up, which drugs are being queried the most, which bugs is being looked at the most. So we have got a very good idea as to what people are up to when it comes to using the app. Obviously, when the users download the app, they will identify themselves as either physicians or pharmacists, where they are interns, for instance, residents or consultants or specialists, and so forth, and where they work for SSMC or they are not working for SSMC, or they are maybe from outside the UAE. So we have got a good overview of who's using the app, and even have the times as well when the app is mostly accessed. Is it daytime? Is it out of hours? So it's quite a useful tool to have. So obviously the hospital pays an annual subscription fee to the app, and we have to justify its worth to our leadership. We have to be held accountable and show why they should continue paying the annual subscription fee. So we tried to assess the impact of the app on 3 key areas. We tried to look at its influence on adherence to antibiotic guidelines. And number 1. Number 2, we tried to look at its impact on stewardship outcomes, specifically days of therapy, daily defined doses of antibiotics, incidence of healthcare associated infections, and so forth, and cost savings, obviously. And also, we had to look at the user experience. We want to know are our users happy with the app? If they're using it, how frequently they're using it? Is it impacting their knowledge or prescribing behavior, for instance? And if they're not using it, why they're not using it, so we can better understand the reasons and try and promote its use among them. So this work on measuring the effect of the app on antibiotic guideline adherence was presented at ECMID in Barcelona. And in a nutshell, it was a before and after study. We basically looked at 3 common indications for antibiotics. Looked at pneumonias, skin and soft tissue infections, and UTIs. So we had to reduce risk of bias by selecting every 5th patient after arranging the patients in an ascending or descending order. And then we used the prevailing antibiotics as a gold standard to judge compliance with guidelines. So this just shows you the way that the patients were recruited. You can see there are similar numbers on both arms before and after implementing the mobile app. And this just shows you that the groups were basically similar in their baseline characteristics. What wasn't similar was the before and after results. So we've seen significant improvement in adherence to antibiotic guidelines, and this was detailed as adherence to in terms of the choice, the dose, the route of administration, and overall adherence. So there was a significant difference, a significant improvement in adherence to antibiotic guidelines. The only one that wasn't significant was the route, but as you can see, it was 97% pre-intervention and 98% post-intervention, so there isn't really much wiggle room there. But in all other domains, a significant improvement in antibiotic adherence, in adherence to antibiotic guidelines. So moving on to the next step, which is currently being finalized. We're just starting the I's and crossing the T's. So we're trying to look at the impact of the app on stewardship metrics. These are really hard outcomes. So we're looking at the impact of the app on days of therapy, and on DDD, and also incidence of healthcare-associated infections, and also on cost savings. So we're doing this by correlating the app use and these parameters. Because as you can see, it's difficult to make a before and after evaluation for this kind of exercise. So we're going to use, for instance, linear regression to demonstrate a correlation between, let's say, increased app use and decreased length of stay, or decreased cost of antibiotics per admission, and so forth. So this is work in progress, and so far we've seen some promising results. The third domain of interest in terms of assessing the impact of the app on our users is the user experience. So we are in the process of submitting an ethics review application to carry out a survey, a quantitative survey, asking the current app users about their satisfaction with the visual appeal of the app, its ease of use, whether they think the content is of high quality or not, and whether it has impacted their knowledge or influenced their prescribing behavior. We're also planning to conduct some qualitative research using focus group discussions, unstructured interviews with, let's say, heavy users and non-users, and try and understand why each group uses or doesn't use the mobile app. So before I finish this, just pictures of the team. So I don't know if they can see the pointer, but at the top left-hand corner, these are our fellows and educational team, together with my fellow consultant colleagues, Dr. Emmanuel, Dr. Robert, and Dr. Adnan, who's our microbiologist. Middle, we've got Ahmed, Jinan, and Rami, these are clinical pharmacists. Jinan is the co-leader of the Stewardship program. She's an ID certified clinical pharmacist, and likewise Ahmed. Rami is our critical care clinical pharmacist. And here you've got the team after a morning review. And down below you've got also the team during one of the antibiotic awareness days. Marlene, Dania, and Leila, or clinical pharmacists, together with Jinan. In the middle here is our colleague Ramesh, ID specialist, receiving an award from the deputy CMO to the ID team as the best consult service in the hospital. And at the bottom here again, you see Jinan engaged with some residents and interns and telling them about how to use the app and what have you. And in summary, I think digital health interventions are a great asset that we should really capitalize on and leverage to improve antimicrobial stewardship processes. And I think the difficult bit is really the antibiotic prescribing behavior. That's really the most challenging bit, and I think we should work around it. And I think the nudge theory provides us with a lot of useful insights that we can reflect on and try and implement in our stewardship practices. Again, using apps to inform clinical decisions is something is still in infancy, and I think we need more research in this area to see the impact on patient clinical outcomes and also providing value-based care. So with that, I'm going to end my presentation here, and I'm happy to take any questions that you may have. Thank you.
Thank you, Zahir, and the floor is open for questions, and I will start with one.
Yeah.
This is a very great presentation, Zahir. Thank you. First, is your mobile app publicly available for everyone? And then the second question is, with the automatic consultations for all the positive blood cultures, we tried this previously when we did our fellowship, and it was so overwhelming that we restricted like to certain pathogens. Is it how you guys managing this?
Okay. Okay. So we have so in answer to the first question, the app is free to download, and you can just go to your App Store or Google Play and just type in first line clinical decision support tool, and you can download it. You need to choose SSMC or Sheikh Shahabub Medical City as your location, and then you can sign in. You can sign up and tell us about yourself. We don't need your name or any specific details. Just whether you are working for SSMC, yes or no. Whether you are an intern, a consultant, a resident, a pharmacist, and then that's it. Um, um, also, the app users have got access to other hospitals that publish their antibiotic guidelines. So you can switch your location to another hospital and have a look at their guidelines. One of the great features of this app is that it allows us as a subscriber, it allows us access to a library of other guidelines produced by hospitals elsewhere. So so you can actually look at them and benchmark your guidelines in terms of content. Obviously, each hospital will have its own antibiogram, so you have to be careful with the choices, and also each hospital will have its own formulary, and therefore you have to be careful with that. But it gives you kind of a benchmark as to how well written your guidelines. Obviously, you can borrow a guideline, edit it, and then publish it as your guideline. So it's quite fantastic in that regard. For the auto consoles, we have managed. So what we do, we intervene and because a lot of it are repetitive. For instance, Staph aureus bacteremias, candidemias, they lend themselves to having a template that you can actually populate with relevant information. So in terms of documentation, it doesn't take a lot of time. But we do follow these patients. So every day we have, on average 10 patients who are on regular follow-up, plus new consults, maybe 5, might be 6, might be 2. On average, every day we see around 20 to 30 consults. So it's fairly busy, but we are somehow managing to cope with it. Obviously, having a fellowship program also helps us quite a lot actually cope with the expansion that our hospital has witnessed. So last year we saw around 8,000 consults with 4 fellows. The year before we had 2 fellows. We saw maybe 5,000 consults or so. So I think fellows also greatly help you have some resilience in your service. We're also blessed to have very hardworking specialists, 2 specialists. So our team has grown in size, and that's also helped us cope with the increased demand. I see your point. You can easily become a victim of your own success, but I think you have to have some coping mechanisms to ensure that you don't get overwhelmed.
Thank you. I think Fathi and have the question. Go ahead, Fathi.
Yeah. Well, thank you so much, Zahir. This is an excellent presentation, and I'm sure there's a lot of work that has gone into it. I remember when we started the stewardship, we have a lot of resistance from the surgeons, obstetricians, and ICU. And I'm glad that you mentioned the education. I mean, very important, the education to the team so they can share it to the decision. So actually what we did, we involved all of them in the stewardship committee, including the surgeons and the obstetrician, and they become advocates for the procedure there. We also linked the stewardship committee to the administration because we need input from the administration. So we're linked to the director of the hospital, actually. And that has given very strong support to the stewardship committee. So also combined ICU infectious disease rounds have helped a lot in cutting down the antibiotic use and the abuse of antibiotics. So I think it's a tough work. Many times you are killing with the surgeons who think they have done a Whipple's operation, and you're going to disturb it with the restriction of your antibiotics. So I'm sure you have faced a lot of trouble, and to get such a success, I commend you on that. Thank you.
Thank you, Fathi. As you said, it's really difficult, and I think the delicate balance we ID physicians have to maintain is really between patient safety and ensuring they have the best antibiotic management versus prescriber autonomy. So all these are physicians who are capable of prescribing antibiotics, and therefore you have to tread carefully. You have to ensure that they understand why you are intervening, and highlight maybe as an expert the best way to manage, let's say, Staph aureus bacteremia, or the best way to handle surgical prophylaxis. One of the issues we faced was some surgeons were keen to extend prophylaxis post-operatively, and that was a challenge, trying to talk them out of this and just restrict themselves to a single preoperative dose of antibiotics. So it needs a lot of people skills, as it were, and it needs engagement, and as you said, making them stakeholders by inviting representatives from each department, from surgery, from ICU, from internal medicine, others, to become members of the stewardship committee is actually quite important, because it makes them take ownership of the decisions made at the stewardship. What we do when we develop guidelines, I don't do it in my spare time or even my work time. I reach out to the chair of the department or the representative and ask them to work on producing antibiotic guidelines with the support of the clinical pharmacist assigned to their area. So by the time it's presented to the stewardship committee, it's actually their work, so they take ownership of it. I think that's quite important, because when they take ownership of it, they feel obliged to honor it and follow it. One thing you mentioned about support from the hospital leadership, that's really quite important. We have been fortunate to have excellent support from our leadership. The CMO has particularly been quite engaged and supportive of the stewardship program. And we meet with the CMO every now and then, update him about the progress we're making. And for instance, the introduction of the app could not have happened without support from our CMO. So it was really good to enlist support from the powers that be and get them on board. And once you talk to them about the impact you're having on in terms of clinical outcomes, length of stay, cost savings, they will listen to you with interest. But thank you, Fatih.
Thank you.
Go ahead, Hamad.
Thank you, Zahir, for the great effort in the presentation. Antimicrobial stewardship is a very difficult area to engage, as you mentioned. Globally, as we know, the concept only 25 years ago, and in the Middle East, so I think less than a decade actually. So you managed to create a very functioning system. Two questions, as you put on the slide in the show you showed about effort and effectiveness, that prospective audit and feedback has very high effort and very high impact. Yet, I think most of our antimicrobial stewardship lack funding. Okay, and I just want to know, how do you do the audit? Because you need to gather information and then you need to circulate this to the sort of clinical team. How you do your prospective audit and feedback to learn from the experience. The other things about your views about rapid diagnostics. Very similarly, our program was established in 2015, and we have a list of restricted antibiotic, broad spectrum antibiotics. In the past, we used to have a cutoff of 48 hours. But by that time, you don't have urine culture, blood culture, so we extended that to 72 hours. So by the time you make an intervention, the patient already in more than 48 or 72 hours of broad spectrum antibiotics. And I just wonder if rapid diagnostics will make any sort of difference. Thank you.
Thank you, Hamad. Excellent questions. For the first one, for prospective audit and feedback, This is done in different ways. So our clinical pharmacists have got an intervention form for stewardship. Again, when I first took over, this form was a standalone form. So the clinical pharmacist would have to audit antibiotics prescribed for each patient on that form, and then go on to a general clinical pharmacist form whereby they document things about, pain management, anticoagulation, etc., etc. So actually, the clinical audit is done in real time by the clinical pharmacists. We eventually managed to merge the two forms into one. So so we can have actually outcomes for the interventions, because when they spot an inappropriate antibiotic prescription, they will document the outcome, whether the physician agreed to stop or de-escalate or narrow or continue. They will document all these outcomes. They're all captured. So that's done in real time by the clinical pharmacist. Also, our ID team also does a real-time prospective audit on all restricted antibiotics. We also have targeted audits. For instance, if we see a spike in, let's say, vancomycin prescription or echinocandin prescription in a certain area in the hospital, we do a drug evaluation and then provide feedback to the teams. So that's also done. Also, we do it in other ways. For instance, most stewardship programs focus on inpatient antibiotic prescribing, and they often overlook prescribing that happens in outpatient clinics. And if you look at the data, actually, most antibiotic misuse happens in outpatient settings. So what we have tried to do, we have tried to set up a prospective audit for antibiotic prescribing in the outpatient setting. Again, this is work in progress, and we are fine-tuning the tool we have to generate a very accurate report. And the aim is to try and feed direct feedback to the physicians, say, hey, you are prescribing more antibiotics than your peers in the same specialty. Could you let us know why you're doing that, for instance? And also we are setting up a prospective audit for surgical prophylaxis. There are some logistical challenges with that because antibiotics are prescribed and administered in a different way in the operating theater. But these are different ways of doing prospective audit. But as I said, it's really, really labor intensive, and IT can be a big stumbling block. But we're also fortunate to have one of the pharmacists who is trained to work on IT systems as part of our team. So that's actually quite helpful. I would strongly recommend considering that. So in addition to your clinical pharmacist, you've got to have somebody from IT with a pharmacy background. That's absolutely essential because they understand exactly what you're talking about. But it's quite labor intensive. It's highly effective, but it's quite labor intensive. And that's what really made us look at process improvements. So because that requires some effort, but the yield is quite high. And I strongly recommend looking at your processes, try and improve them, and get the benefits that way. In terms of rapid diagnostics, I think they're a double-edged sword. I mean, I'm a virologist by background, so I'm all for rapid diagnostics. But as I mentioned earlier, for instance, the respiratory PCR panel, I think it opened the door for a lot of antibiotic misuse because physicians don't really understand their report. I don't know whether you have a similar experience like we have in the hospital, where the lab will basically dish out all the results, including your CTXMs and MEC-A results and all that kind of thing. And you see, physicians trying to add antibiotics that are not really relevant for the clinical context. So we have accepted. Also, we are part of a network. So our IT system is shared with other hospitals in Abu Dhabi. So we're part of a network. So we cannot really change the system to our liking. For instance, some time ago, the default antibiotic prescribing duration for any antibiotic was 7 days. Now we fought, tooth and nail to bring it down to 3 days, but that was not accepted by most other hospitals. So we settled to 5 days, and because it's 5 days, we've got to intervene at 3 days. So I think you try and do what is feasible in your environment. And we're using the soft stops to try and help us manage these things. We're also working on the microbiology reporting. Again, microbiology services are centralized in Abu Dhabi. So we don't actually own the lab. The lab is actually central. So the microbiologist sits in another hospital. So we don't have direct influence on the lab. And therefore, we're trying our best to reach some middle ground by saying, well, look, these respiratory PCR panels are quite helpful, quite useful, but maybe we can look at the way they are reported just to try and deter clinicians from prescribing unnecessary antibiotics. And I'm not sure if all physicians will accept sometimes rapid diagnostics as a good enough reason to stop antibiotics. I'll give an example of the CSF PCR panel. If somebody comes, let's say, to ICU with, I don't know, altered mental status, seizures, and they had a CSF which is plumb normal, they had a CSF PCR panel which is absolutely negative. They say, oh, we can't stop now, we want to wait for the culture result to come through. I mean, I don't understand that. I'll probably happy to accept the PCR panel and stop because the patient doesn't have meningitis or encephalitis. So I think it again boils down to behavior and also perceptions. Most of these clinicians have no idea about microbiology diagnostics or how to interpret microbiology reports. I'm sure some of you are familiar with some physicians, surgeons, let's say, trying to look at the MICs in the microbiology report and maybe going for the one that has got the smallest number and not really knowing how to interpret the report. So these kind of reports are not helpful. We're trying to bring the microbiology lab on our side. We've got a diagnostic stewardship initiative that will look at all these things and try and improve clinicians' understanding of these rapid diagnostics and how they can use them in a positive way to influence their management. But as I said, sometimes this just backfires, resulting in more antibiotic prescribing because clinicians have got limited understanding of these rapid tools. Right, any more questions?
Zahir, thank you so much for this great presentation. I just wonder, is there when you look into this role of AI and stewardship, I always wonder if there's any prospect in that, using the AI. I mean, everybody's talking about the AI. I was in a conference just a month ago. There was a lot of talk about using AI for stewardship. I don't know if you can hear me because I'm driving, but this is something interesting. You guys might need to look at this.
Yeah, the voice quality is not fantastic, but I think you'd ask about AI and antimicrobial stewardship. I'm yet to see, examples of AI interventions in stewardship that goes beyond what we've already described, as in soft stops. So what we're describing is basically an algorithm. Let's say for the soft stops for antibiotics like anti-pseudomonal or anti-MRSA or duplicative anaerobic coverage. It's based on a simple algorithm. So you specify the criteria. So when we fill these forms with the IT department, we have to specify the triggers. And that's basically algorithm. And as you know, algorithms are probably the simplest form of AI that we have at the moment. So yes, these interventions have got some AI attached to them, but they are not the kind of maybe AI that we want to see in maybe 5 years' time or so. I think what we should work more on is really the prescribers and how to influence their behavior. As you can see from this slide, education requires some effort, but the impact is low. And that boils down to physicians' attitudes to antibiotic prescribing. And that's the difficult bit to actually control. But I think maybe nudging, maybe redesigning the choices that they have, make it more appealing, will maybe make it more attractive. I think, so, yeah, part of the success we've had with the mobile app is the fact that it has some decision support tools built into it. So I'll give the example of the pneumonia. We've actually designed a tool for risk assessing patients for rabies. Please feel free, have a look at it and give us your feedback. That's based on Public Health England rabies guidelines. So basically risk assessing patients, according to certain criteria. So you have to input the various variables and then it will give you a recommendation. So again, this is a form of AI that you can actually embed in these mobile platforms.
Can I ask a question? I
Yeah.
couldn't raise my hand. I don't know how you guys do it. Just from a practical point of view, an automated prescriptions بتحت ال MRSA screening, decolonization, and how do you actually do it? Is it something that's already?
Yeah. So again, it's based on algorithm. So your electronic medical record, let's say Cerna or similar, will have a microbiology result with a positive MRSA culture. And you make a rule or create an algorithm whereby when a physician opens the file, they will have an alert saying that this patient is colonized with MRSA. And this is an auto-generated prescription for topical chlorhexidine and mipiracin cream and what have you. And then you just have to sign it. Once it's signed, then the alert ceases to exist. Okay, so so the IT form that you have to fill in is actually quite inquisitive and asks for very specific steps or criteria to be fulfilled before the alert is triggered. And not only have to specify the triggers, you also have to tell the IT person when the alert should stop. So it works.
It's very excellent work. Excellent and amazing. I'm amazed.
شكرا. Okay. Are there any more comments? Or I think we are slightly over time by 5 minutes or so. If no more comments, I just want to leave you with those pictures. I think, as I said, it's really a team effort. Stewardship cannot be done by either physicians on their own. We have to involve other people. One thing we found really useful, the app introduction was actually done via a champion group from internal medicine. So we actually teamed up with internal medicine physicians, a consultant and a few residents, and we worked with them. We wrote an options appraisal. We interviewed 3 providers. We identified the pros and cons for each one, and then we made a decision based on that. So internal medicine department, for instance, not only that they are heavy users of that, but they are heavily promoting it as well. And for us, we think the use of the mobile app has actually cut down a significant number of unnecessary referrals or consults to us. So if the consult is very simple, very straightforward, and there's an answer on the app, you just ask the caller to look up the app and get back to us if they can't still figure out the right answer. So with that in mind, I'd like to thank you for your attention and your time, and wish you all the very best. And I'm happy to take any more questions if you have any.
Thank you very Zahir for very interesting and fascinating again, and really very accomplished project. And hopefully you'll keep us updated on how you progress through the years and follow the curve, and hopefully we'll keep the standards up. Yeah, thank you very much again.
Thank you. Thank you. Thank you all very much.